Man with us?
Hi, no man.
Yeah.
Yeah, hi.
Good.
Hi.
Let's get started, please.
So, yeah, so this is your case, okay? So you've got these three questions. So what's this investigation? How's it created? And what are the clinical indications for its use? So if you want to put down some points for each of those three questions, and then we can spend the next few minutes just going through it, okay?
Okay, 2 minutes over now, so we could start.
Okay. So, man, do you want to give me an
Yes.
answer to the first thing?
This is the picture of a radioactive isotope scan showing the knee joint with the prosthesis in place, and there is a high activity seen around the femoral prosthesis on the posterior aspect and also over the anterior aspect of the femur. And there is also an increased uptake seen of posterior aspect of the tibial prosthesis as well.
Okay, so what did you call it? What was the scan particularly called?
It's a radioisotope scan. I think it's.
Okay, so so it's CT scan, isn't it? Yeah. So it's a positive emission tomography scan with a CT of a total knee replacement, as you say. Okay, fine. And so how was it created?
So this is created on the principle that radioisotope is injected into the body, and it goes into the tissues where it metabolizes and release gamma radiations, and gamma camera is used to detect those radiations, and then it makes a picture on the film, and depending upon which part of the body is absorbing those radioactive dye and releasing gamma rays, the picture is taken and give the information or image. It is used in cases like as we have seen used with the CT scan, or also can be used with X-rays or bone scan to see the metastasis, primary bone tumor, loosening of the implant, and occult fractures when if we cannot see. So these are its uses.
Okay.
The advantages are the renal function should be normal renal function, and because the dye is excreted through the kidneys, and there is a high radiation involved in this. It is expensive and not easily available.
Okay, very good. So if we go through the answer for how's it created, so you covered some good points there. So it's a form of nuclear imaging, good, and it usually takes sort of about 45 minutes to carry out. I'm not sure if you mentioned injection of FDG or fluorodeoxy glucose. It's good to mention that type of, because it's a radioisotope of fluorine 18. So that's combined with the glucose, and it's this that's taken up by sort of areas of high metabolic activity. So the cells that are carrying out high metabolic activity, wherever they might be, take this up, and so they undergo irreversible phosphorylation, and so they accumulate within the cells. They can't be exported. So the whole you've got this radioactive isotope now that's then emitting the positrons. Okay, so these positrons then collide within the electrons in the soft tissues, and they generate photons as a form of energy, and this is then picked up by the PET cameras that absorb this and then transfer that into electrical signal that create your image. Okay, so that's a PET scan, but then you can combine that with a CT scan, and it can then provide an anatomical location of where that activity is. So it's an even better way of showing you where the activity is. So I think you mentioned a lot of the points there. Maybe just a bit more detail of of the radioisotope that's used, the process in which you generate the image is reliant on the generation of the photons from the breakdown of the radiation that hits the electrons within the soft tissues, and that's how you get the signal. And then the overlap of the CT with the PET scan image, because you can get a PET scan, can't you? But this is a CT PET, so you're combining the two and you get an anatomical location for the pathology. So that maybe you've got an overall understanding there. Maybe just brush up on a bit of more detail about the exact radioisotope. And going on to the next part, you then went on the clinical indications. So you mentioned that from an indication point of view, so areas of malignancy, so both benign and malignant tumors, parasitic infections, inflammatory arthritis, and things like Paget's disease. So anything that has high activity, cell accumulation. So it's great for showing those, but it doesn't always differentiate between those conditions, because so it's not, it's sensitive, but it's not always specific. So it's showing there's activity, but you've got to put it as part of an overall clinical picture of why you've arranged that investigation for that particular patient, what you're querying, etc. Is that sort of is that clear?
Yeah, thank you.
Any questions?
That's very good.
Okay,
That's very good. So we can move now to the third candidate.
What did you make of this one then?
So this is the AP and lateral radiograph of a 2-year-old child. It shows anterolateral bowing of the leg. This is anterolateral bowing of the leg as evidenced by the apex of the deformity being anterior and lateral. It is associated with neurofibromatosis. Almost, I think 50% of the time, this may be associated with neurofibromatosis. So I'll look for, assess the child in terms of looking for neurofibromatosis markers, cafe au lait spots, anything in the eyes, any family history, or any obvious neurofibromas along any of the nerves. In terms of bowing of the legs, it may be anterolateral, as in this, associated with neurofibromatosis with a high risk of pseudoarthrosis if it fractures. Then there could be anteromedial bowing, which is associated with fibular hemimelia. And there could be posteromedial bowing, which essentially self-corrects most of the time, but needs to be monitored for any limb length discrepancy as the child grows, and could be having calcaneal valgus, which also usually corrects. In terms of management sorry?
Yeah, good, carry on.
In terms of management, I would want to protect this child with a brace while it is bowed to prevent any fractures. And he said it is painless, so but he need to be protected because once it fractures, there's a very high risk of the pseudoarthrosis, non-union, and difficulty to achieve union once it fractures. So it has to be protected with a brace to prevent that. If it presents with the fracture, then it's a very complicated scenario. It will need an MDT approach. I would discuss with the specialist, but the principles of this management would involve a combination of osteotomy, stabilization, and grafting. Combination of those three, and it might need to be done in a staged manner.
Okay. Before I move on to the answers, I'll just ask you a couple of questions. So what type of fixation would you use? Would you use a plate and screws?
No, it would have to be intramedullary.
Okay. All right. And is there any, you can have one more word that you might need to consider in this case, should they go on to develop pseudoarthrosis?
Osteotomies. Corrective
yeah, if that fails.
Okay.
All right, let's move on. So this is the answer. So you were correct. This is an AP lateral radiograph, right lower limb, skeletally immature patient. It is anterior lateral bowing, and you picked that up correctly. You did mention the MDT approach, and these are the types which you mentioned correctly. So the posterior medial one is the physiological one, which usually self-corrects. The anterior medial one is the one associated with fibular hemimelia. And again, you know, you monitor it, you might need to do reconstructive surgery. And it's got associations with things like ball and socket, ankle joint and things like that. And then the anterior lateral one is the one that you often get in the exam because it's the one that's associated with neurofibromatosis, and you correct 50% have got neurofibromatosis, but only 10% of neurofibromatosis patients have this disorder. Total contact cast, intramedullary nail, you're correct. You don't use a plate and screws. There's a very high risk of failure. You can use external fixation, bone graft, as you said. And, you know, if you fail to get union, the last resort is amputation. And because they're children, generally you can fit them with an orthosis and they do quite well. But that is the last resort, and we do a lot of the other things first. So well done. For me, that was a very good answer, and you got all the points.
Extra word you mentioned, was it amputation you wanted?
Yes. Yeah. But just like to put that in at the end, because it is a possible outcome. It's probably a lot rarer these days, but we have to put it in there because it's a big, you know, it's rare, but it's an important complication. Okay, yes. So next, clinical. You may get spine. I had horrible spine in my upper limb clinicals. I had it as my long case for my upper limb long case. So how did you go with this young girl?
So this is a clinical photograph showing this young lady's back, and also it shows on the left-hand side, and on the right-hand side it shows Adam's forward bending test. On the left-hand side, I can see a curve, a thoracolumbar curve with apex to the right, and a rib hump on the right-hand side. So I will begin by taking history from the patient about the progression. So how the rate of the progression, is it painful or not? Does she have any red flag signs of spinal problems like pins and needles in the post legs, weakness, bowel or bladder problems, and any gait problems? Also, I would take history about when did her menarche start, and family history about any similar conditions in the family or any bony dysplasias, and also about having any lumps elsewhere.
Okay, so the school nurse noticed it about 6 months ago. She doesn't have any pain. She's a bit fatigued at the end of the day. No neurological symptoms. She started menarche 6 months before. And there's no family history of any other problems. So tell me how you're going to examine this girl.
So I'll examine her first. First, I'll examine the gait. So I will ask her to walk and see if she has any sort of gait, including any lower limb problems, long limb discrepancies that can cause a compensatory curve. Right. Then I will examine her standing. So looking from the back, I have already had a look. I'll get a closer look to see if there's any evidence of spinal dystrophism.
None of that.
Yeah, like lipomas, hairy patches, also any skin discolorations, coffee ole spots that can be.
No, all clear.
Then I will look from the side for the curves of the spine, the kyphosis of the thoracic spine, and lordosis of the lumbar spine. Mm-hmm. And then looking from the front, what the shoulder levels too. It looks like the left shoulder is a little bit lower than the right, and I don't see much pelvic. Oh, so yeah, there's a bit of pelvic obliquity too. So the left pelvis is a little bit higher than the right hemipelvis. I'd like to put a block test to if there's any limb length discrepancy identified by the knee levels too. If not, I will get the patient to lie down, perform a full neurological examination of both upper limbs, lower limbs, including motor power sensation, also for abdominal reflexes. And
Okay, tell me how you do the abdominal reflexes.
I divide the abdomen into 4 quadrants, and I begin striking from lateral to towards the midline, and see if the umbilicus moves towards my my pen or my scratch.
Yeah. All right. So her neurological examination is normal.
Yeah.
So what would you like to do next?
I'll get a full standing X-ray for the whole spine, AP and lateral, PA, I'm sorry, and lateral. Also, I get supine bending views to the right and to the left. So I will be looking at this on the standing static views, or the standing views. I'm sorry. I will look to the severity by measuring the Cobb's angle, and on the bending views, I will look for the correctability of the deformity.
Okay. And I guess I think that's come up to our 5 minutes. But so the history, you're correct. Pain, neurological symptoms, age of menarche. Why is the age of menarche important?
Because the following year after menarche has quickest or fastest rate of progression, that's why if the patient is within a year or before menarche, I would suspect that this curve will progress. However, if the menarche was years past, the risk of progression will be lower.
Yes. The point of menarche is that I agree with you, it can progress quite rapidly, but usually the growth plates, so you reach skeletal maturity round about 18 months after the onset of menarche in women.
Yeah.
You can use that as one marker of skeletal age. The other thing you could talk about was Reiser's signs to see when they're going to fuse, because when if you're still growing, if you're in a growth spurt, then the curve is going to progress quite rapidly. So that's why you need to have some idea of when they're going to fuse. So we know that girls generally are around about 14 years old, whereas boys are 16. But the menarche and the Reiser's signs on a pelvis X-ray will give you some idea in assessing their skeletal maturity. Adams forward bending test, look for rib prominence, structural deformity. Yeah, you described that to me. I know it's described as a rib hump. I was taught that saying hump like rib hump in front of adolescent girls can make them quite paranoid. I was an adolescent girl once. I don't think it would have made me paranoid. So I always make it a point of saying rib prominence rather than hump. Having said that, I was in an exam and I said rib prominence, and the examiner said, this girl knows what it is, just call it a hump. So, I think it's nicer to say prominence. But, if you say hump, I think people know. You described the neurologist and that was fine. Indications for MRI. Yeah, there would be those things. I think in general, we tend to do MRI scans anyway, because everybody expects an MRI scan and everybody's a little bit scared, but we generally do, I think. Radiographs. Now, I was taught that an AP radiograph gives less radiation to the breast tissue, but there's only certain areas that do it. It's not a generalized thing. And I think so long as you're asking for the view and the bending X-rays to assess them, because you're going to look for the Cobb angle, then that should be okay. You could mention AP, but as I said, not everywhere does them. And then the principles of treatment. So this is a clinical exam, so you may not get to this, but you've got your choice of observation, bracing, and surgery. If you're going to observe, you need to be able to say how often you're going to review them. We used to review them every 6 months to see if they progressed. Then we went to 12. Bracing, what you need to know about bracing is they need to wear it 23 hours a day. And if you're an adolescent girl and it's the middle of the summer, you are not necessarily going to be compliant with that brace. So just be aware of that. Pressure area things, it's horrible, but it may be a better option for some if they've only got, a few months before they become skeletally mature. Then you may get away with a brace, because the option is surgery, and surgery to your spine is not really a pleasant thing to go through for anyone either. So you could, in this Viva, get to talking about how you would measure a Cobb angle. My experience of having spine in the exams at the clinical stations is that it's just about assessment and ruling out any major neurological problem. But if you got it in Viva, you could be asked to calculate Cobb angles and things like that. Okay.
Yeah, just going to give you a minute just to formulate your thoughts about this 45-year-old man with groin pain. Okay, Zafar, do you want to tell me what you think of these images and what might be going on with this?
So the radiograph of the pelvis with both hip, this shows that there's increased sclerosis on the left hip, although I couldn't see any collapse or any distortion of the femoral head. Right side on the radiograph looks okay, and in the image below of the T2 weighted image of the MRI shows that there is area of sclerosis, and the area of there's some lysis there on both femoral head, more on the left side. So I'm thinking more
for the MRI. Tell me about the MRI.
So on the MRI on the left side, I could see that on the femoral superior aspect, the superlateral aspect of the femoral head, there is decreased signal intensity, and apart from that, most probably there is a line going there showing subchondral collapse. Maybe the crescent sign is there on the left side, left hip, and on the right hip, there is decreased signal intensity on the superior aspect, but there is no crescent sign there.
Okay, so what do you think the diagnosis might be here?
So my diagnosis is avascular necrosis of the femoral head bilaterally, more on the left side than right.
What are the risk factors for developing AVN that you might be aware of?
So the risk factor, like if it could be one of the most common is post-traumatic. Apart from that, then idiopathic, and there is apart from that, other risk factors involve irradiation or alcoholic if the patient is smoker, and any sickle cell disease or any hypercoagulable state. Then there's, if the patient is a diver, then we could think of Kyson's disease as well. And apart from that, any other immunosuppressant conditions like ongoing chemotherapy or radiation.
That's fine. So what do you know sort of the pathogenesis of AVN? What's the thought of what's going on? Why does it happen?
So there's like one of so there are different theories, but one of the theories like intravascular coagulation, that there is the arteries supplying the femoral head are affected. Then the other one is like venous stasis, and the other one is like fat microemboli theory, where the microemboli block the flow to the femoral head. Yeah.
That's fine. So tell me a little bit, do you know any sort of how you might be able to classify it?
So in terms of classification, that's a Fickett-Arlet's staging, and with the stage 0 is like there is nothing on the, no changes on the femur, on the radiograph as well as MRI. The changes were seen on the histology, and then stage 1 is the changes could be seen on the MRI only. In stage 2, there is sclerosis and fragmentation of the femoral head. Then it is divided into stage 2 and 2B. In 2B, there is the crescent sign present, where there is subchondral collapse. And then in stage 3, there is further fragmentation of the femoral head. Then in stage 4, like it's complete arthritis on the femoral as well as on the acetabular side.
Okay. So what's the significance of the crescent sign?
So the crescent sign signifies that there is like irreversible collapse of the femoral head, and then it helps in like guiding our towards our management. Because if the crescent sign is present, then we have to go towards the replacement rather than doing any of the procedures like.
So you're touching upon management now. Okay. So how would you what would you consider doing for this chap?
So in terms of management, like on the left hand side, there is subchondral collapse already present. So we could go for.
Let's say that on the left side it's not quite collapsed. It's
yes.
Maybe pre-collapse stage.
Yeah. So then there is option of what's called drilling through the cortex, core decompression is the word. Yeah, core decompression.
What might you consider before you do that? Because that's invasive, isn't it?
Yeah. So in terms of like initially, I could go for like non-operative treatments.
Okay.
So I have to assess, like clinically examine and assess through his history is like how much his functional and daily activities are limited. If he's clinically not limited and the pain is not severe, then we can like postpone any surgery as far as to a later time as far as we can.
Okay.
Apart from that, there is like options of starting bisphosphonate, but I'm not sure how much effective they are.
Okay, so that's an option, isn't it? So that is thought that might prevent collapse. Okay, you mentioned core decompression.
Yeah. So core decompression could be done before the collapse of femoral head has taken place. You can drill up to the subchondral bone to relieve the intraosseous pressure and stimulate the healing response.
Okay, fine. And what about if you've reached the collapse stage now? What are you going to do? Sort of stage 3.
So there's like if we want to delay the replacement stage, like there's one other procedure in which we can do this fibrillar vascular graft. I can't remember the name. It was technique something.
And let's say he's advanced to arthritis now. So what?
So yeah, in terms of like advanced arthritis, then
he's 45, isn't he?
Yeah. So he would need total hip replacement. He's 45, so I would better go for the uncemented total hip replacement for him.
Yeah. Okay. And what sort of bearing surface for this age group would you?
So yeah, in terms of bearing surface, it would be I would try to use best would be, I think, metal on polythene.
Would you consider metal on poly in this age group?
No, generally in 45 years. I'm not sure. Yeah, generally 45 years age group, we don't use that.
No. Okay. Great. Right. We better get through through the answers. So you start off well. So you did the diagnosis. You mentioned the changes on the radiographs. Quickly mention it's a T2 coronal MRI. Okay, and you can see the sort of double line sign, and this is all consistent with vascular necrosis. So classification, you rattle through this quite well. I think you covered that quite well, which is good. I don't think I had any major issues with what you said about that one. Largely the management is guided by that, isn't it? So you've got sort of split up in your head, sort of pre-collapse, collapse, and then OA. So the first sort of 2 stages you're thinking about is pre-collapse. It's still, I can still salvage something here. Protected weight bearing, consider bisphosphonates, core decompression like you mentioned. Some people drill up and put stem cell injection as well up there. Some people use fibula strut grafts as well. There's the tantalum rods as well. You might have seen those. Some people use that as well. That's a consideration. And then once you go into stage 3, you kind of, you've got some collapse now. You've got the crescent sign. You're thinking possibly rotational osteotomy could be considered, to offload that and put it onto, weight bear different part of the femoral head. And then once you get into the stages of 4 to 6, it's just basically different stages of OA, isn't it? And then you're talking about, salvage at this point. There's nothing really else you can offer this guy apart from either continue as he is or bite the bullet and go down a replacement route. So you've got to make sure that you know about the NGR data. The young guy, don't mention metal on poly, okay? You got to be thinking ceramic bearing, and really ceramic on poly actually works quite well. You can say ceramic on ceramic, but the NGR does suggest that ceramic on poly do better. And you can argue ceramic on ceramic has got risk factors. It's more expensive, it's squeaking, it's brittleness and fracture and things like that, which you don't necessarily get with ceramic on poly. So and you can use uncemented. You might think, well, the local biology might not be great because he's had this condition, but that's not been proven. You can use uncemented in these cases. Okay, so good. So overall, you've got the knowledge. Just polish up, then you'll be fine.